I started feeling not well in October, November of last year. I had numbness in my leg, my lower back was killing me, the fatigue was horrible. So I called my primary care. He said there was a new procedure that was available.
Hundreds of thousands of women visit their doctor each year with a common condition known as uterine fibroids, non-cancerous tumors that affect more than 25% of women between the ages of 30 and 50.
In the hands of my medical professional, OBGYN, I find out that I am riddled with uterine fibroid tumors. I had no idea. I lost control of that part of my life, and certainly that part of my body.
This condition can cause many symptoms, such as heavy and prolonged bleeding, bloating, frequent urination, and pelvic pain. And these debilitating symptoms often force women to make extreme changes in their everyday routines and lifestyle. In the workplace, employers may not realize that fibroid symptoms can be directly related to attendance and productivity.
I'd always had really bad periods, and where I would usually end up staying home from work one day at least. Anywhere from 7 to 10 days out of the month, I took a lot of heavy-duty ibuprofen, Motrin. You lose at least a day's worth of work.
When fibroids cause severe symptoms, a majority of women get the same recommendation from their doctors, a hysterectomy or surgical removal of the uterus.
I hear the dreaded word. You should have a hysterectomy. That echoed in my spirit. I didn't want a hysterectomy. But let me tell you something, I'm a fighter, and there was no way I was going out like that. I was not gonna give up my uterus. I wasn't.
Hello, I'm Casey Kaufman. In the next few minutes, we will discover what other options are available for women suffering from fibroids. For many women, their fibroids don't cause any symptoms and can be left alone. But once a woman's fibroids become symptomatic and interfere with her quality of life, she needs to figure out how to treat them. Traditional hysterectomy and myomectomy requires surgery and 4 to 6 weeks of recovery. But there are less invasive options. Uterine Fibroid Embolization, or UFE, is a proven, safe, and effective non-surgical option. In fact, while nearly 200,000 women worldwide have had a UFE, many women aren't even aware that this procedure is a treatment option. And from your employer's perspective, women who have had a UFE miss far fewer workdays for recovery than women who have had major fibroid surgery.
I heard about the procedure that I had on a commercial, imagine that. You know how we don't pay attention to commercials. But this commercial caught my husband's attention because he too was fighting to keep me the whole woman that he married.
So Sharon, I'm going to spend a few minutes just talking about fibroids and about uterine fibroid embolization. I think the real goal at the end of this is for you to understand what UFE is and how it fits into the various treatment options available to you so you can make the best choice, obviously with my help.
Okay.
What we're going to do is we're going to work from the artery by the hip on the right side. We're going to clean, shave, and numb the skin over the artery, after which we thread a small plastic catheter into the arteries. Through the catheter, we inject X-ray dye and take pictures, and that's called an angiogram, and that's a picture of the blood vessels. Since fibroids are very vascular, the arteries of the fibroids are very enlarged and very visible on the angiogram. And that allows us to guide our catheter specifically into the artery supplying the uterus and fibroids, first on the left and then on the right, and then through the catheter inject some inert spheres which block the blood supply to the fibroids. These spheres are actually trisacral gelatin microspheres. Once the catheter is in the right position within the artery, we inject these spheres and they flow preferentially to the fibroids, not only cutting off their blood supply so they'll no longer bleed, but also causing them to shrink and die, but also cutting off the estrogen that reaches them and otherwise causes their stimulation and growth. After the procedure, we remove the catheter from the groin, apply a little bit of pressure, and the whole thing's done. The procedure generally takes less than an hour.
What's the success rate of this procedure?
For control of the bleeding symptoms, about 95% of the time women will have tremendous control of the bleeding and find that their periods return to normal. It's actually quite common to miss one period after the procedure, With regard to the bulk symptoms, pressure, pain, bloating, urinary frequency and urgency, low back pain, sexual discomfort, we see relief about 80% of the time. It's not 100% of the time because the fibroids on average shrink by about 40 to 50%, which is essentially what they would do, by the way, after menopause. So having remaining fibroids is not a problem as long as they're not bleeding, not causing symptoms. So it's been enormously successful.
What are like the risks or complications that would be associated with UFE?
Well, as with any procedure, even though it's a minimally invasive procedure and therefore associated with fewer complications, shorter recovery, there are, of course, some potential risks that you need to be aware of. First of all, anytime we put a catheter into the artery, there's a risk of bleeding or infection, which is very uncommon. There's always a chance of damage to any of the blood vessels we put the catheter. Allergic reaction or kidney problems from the X-ray dye, also very, very uncommon. There's a chance of inadvertently cutting off blood vessels that we didn't intend to. We haven't had that happen. It's been described, but it's, again, exceedingly rare. Every time you cut off the blood supply in this area, there's a chance of injury or infection in the uterus, which can result in hysterectomy anyway, which is about 1%. The risk of having premature ovarian failure or early menopause, and for women in their 30s and early 40s, is about 5%. As you get a little bit older, in your mid-40s, it's as high as 10 or 15%, and as high as almost 20% as you get close to menopause. Now, obviously, many of those cases are women who are going into menopause anyway, and that's sort of an expectation.
Can you give me like a picture of what recovery is like?
Sure. We know that there's going to be some pain, some discomfort after the procedure. The first night's the worst night. It's actually been described as severe period cramps or even early labor. And it's actually quite critical that we give you pain medication, that first night to help control it. You don't have much pain during the procedure. The fibroids aren't dying right away, plus we're giving you pain medication during the procedure. But the night of, we actually anticipate some discomfort, and we have to give you pain medication to stay ahead of the discomfort. The next morning, the pain subsides considerably. The pain is only moderate. It continues to subside over the course of the next few days. We tell women that you have to figure about a week off from work. Although there's no limitation, it's just a matter of how you feel, how much discomfort you have, whether or not you return to work. And that's obviously a big advantage compared to surgery. It's also not uncommon around the procedure to have a little bit of fever, a little bit of nausea, a little bit of constipation. That's somewhat due to the pain medications, even more so than from the procedure.
Would my insurance be able to cover it?
Essentially, all private insurers cover the procedure. It's not been a problem. So the answer is yes, your insurance will cover it.
Great. What are the chances of needing a second procedure, like fibroids begin to come back or more notice? What are the chances of that?
Yeah, that's a great question. So essentially, in almost all cases, we effectively treat all the fibroids, front, back, top, bottom, big, small, old, new. They all get treated and they all die and start to recede. However, overall, there's about a 10% chance of having recurrent symptoms over the next 5 to 10 years. And there are two reasons why you'd have recurrent symptoms. One would be, on rare occasion, there's some technical difficulty and we're unable to completely interrupt the blood supply, so we don't entirely kill the fibroids. The other is, on occasion, the fibroids actually draw their blood supply from other arteries other than the uterine arteries. But for those reasons, there's about a 10% chance of recurrence in follow-up.
Dr. Mott, what are the treatment options available for women today, and how can they determine the best course of treatment for them?
There are many treatment options available. The treatment really has to fit the patient. It has to fit their lifestyle, it has to fit where they are, and as far as their fertility, it has to fit the number of masses that they have and all of their symptoms. Certainly, many of them will not experience any problems throughout their lifetime, but a certain number of patients will have some difficulties. They'll come in complaining of pain and pressure, heaviness, increasing bleeding with their cycles, heavy bleeding, clotting, even tremendous anemia. Now those ladies have a big decision to make. It depends on how large the fibroids are, how severe their anemia is, as to what will be recommended. And we as gynecologists try to move away from surgery and to things that are less invasive. We have several procedures that are available, and certainly those need to be discussed. The FDA has approved a GnRH inhibitor, which is called Lupron. That drug can be used to shrink fibroids. It usually is used for about 3 to 6 months.
It has some negative side effects?
Oh, yes, it does. Because fibroids are estrogen dependent, it places you in a menopausal-like status. So you might have hot flashes, you might have dryness in the vagina, and certainly a lot of ladies have mood swings. But the thing to remember is that it's time sensitive. So we're trying to treat a problem. We want to get the fibroids smaller so that we can do some other things to keep them from being a problem. Sometimes with that medicine, they won't need anything else. If they do, then we can move on to other interventional type procedures. One of those is fibroid embolization. The bleeding, the problems that they were experiencing, pressure, all of those are usually relieved.
And is this often used in relationship with an interventional radiologist coming in and working in partnership, in tandem almost?
Right. Certainly, this is a team. The patient is part of the team, the gynecologist is part of the team, and the radiologist is part of the team. But once they see them, then the procedure is performed, and then they follow up with the gynecologist. And certainly, if new fibroids develop, then we actually sit down and talk about whether or not they're candidates for focused ultrasound, MRI-focused ultrasound, where we actually heat the fibroids to make them smaller.
Lifestyle really helps drive a decision for a lot of patients when they come in and they say, I'm working and I'm concerned about recovery periods. What do you tell them at that point?
Well, most women just can't afford to take off 6 weeks, 4 to 6 weeks for a major surgical procedure. So we oftentimes give them options on endometrial ablation, where we actually are able to burn away the lining of the uterus so that they don't have bleeding, if bleeding is their only symptom. But we have to remind them that certainly that does not take care of the fibroids. The fibroids are still there, and certainly as long as they have estrogen production, they will still have growth in their fibroids.
The key is to be an advocate, and that is to be well educated. What's the bottom line advice for patients?
The bottom line is that you have a diagnosis. It's your responsibility to get the information on that diagnosis. It's your responsibility to make questions for your doctor, to come in and talk to them, to give them an idea of who you are and what you need, what will work for you and what won't. And that way the doctor can be a teammate with you in making sure your health care is delivered.
Dr. Mott, great advice. Thank you very much.
I had the UFE procedure on a Thursday. Monday, I was back in the game. I couldn't believe it myself.
We're moving towards a collaborative model, it seems. An OBGYN working with an interventional radiologist to help a woman suffering from fibroids. How would that care look like? What would it look like working with a team approach?
I think you're absolutely right that in the modern era of medicine, we need to approach this as a team approach, where in this case, the obstetrician gynecologist and the interventional radiologist and perhaps other caretakers are involved with the patient in the active process of making the best decision. As it turns out, for uterine fibroid embolization, the great majority, 9 out of 10 women, are very, very good candidates for this procedure and may not be aware of this as a treatment option. And it's very important that they're aware of all their treatment options. Really, most women who are considering treatment for fibroids, predominantly for bleeding, should see an interventional radiologist or somebody familiar with uterine fibroid embolization to see if they might be a good candidate.
Because if they are a good candidate, the implications on lifestyle happen to be huge.
Oh, it's actually very dramatic. If it comes down to a comparison for a woman between uterine fibroid embolization and hysterectomy, the differences are marked. For women who have to undergo hysterectomy, you're talking about 4 to 6 weeks of recovery, out of work, incisional pain, potential short and long-term difficulties related to that procedure. In contrast, uterine fibroid embolization is a procedure that's associated with fewer complications, shorter recovery, and less discomfort. Most women can return to work after a week with some minimal pain for several days, which can be generally treated very, very well, and allows them to return to a normal, healthy quality of life very, very quickly. I think women need to take control of this aspect of their lives, not just sort of seek the first alternative, but to work as an active participant in their care to find out all the choices, make the best decision, weigh the options, and understand the implications of everything and their quality of life and their long-term health.
The doctor who was doing all my surgeries, the gynecological surgeon, he laid all the choices out, and again, he pushed for the UFE. Just knowing my history, knowing the fact that, you know, everything else that had been removed up until this point had been fibroid. And he was just like, you know what, think about it, go meet with them, talk with them, whatever you decide, you know, come back, let me know. We can always go the surgical route if for some reason this doesn't work type of stuff. But this is a good, you know, first option type of thing, and save the more drastic cutting and removing for a last option.
When it comes to best practices for fibroid treatment, the key word is collaboration between the OBGYN and the interventional radiologist. Dr. Mott, you're an OBGYN, and Dr. Ronbach, you're an interventional radiologist approaching a case involving a woman who has fibroids. How do you collaborate to create the best case scenario for treatment?
I think for us is to make sure that we've evaluated the patient completely, that we've assessed everything that she has going on, and then to talk to the patient and see what would be best for the treatment. Certainly, we have to take into consideration her lifestyle, where she is in her fertility as far as when she's planning for pregnancy, if she's closer to menopause, how low is the blood level. All of these factors have to come together. And then we talk about exactly which one of the minimally invasive procedures would be necessary. And certainly sometimes we're dealing with fibroids that are in the lining of the uterus, and Dr. Ronbach will say, well, no, that's not mine. But certainly the fibroids that are on the outside, they're in the muscle wall, they're in the lining, and she wants to get back to work, certainly the IR is going to be the place to go.
When you're called in this case and you're talking to a patient, what do you outline to that patient about the pros and the cons of various treatments?
Sure. Well, first of all, to respond to what Dr. Mott said, I think it's important to recognize that the gynecologist is providing the long-term reproductive and gynecologic health of the patient. Obviously, we evaluate a lot of things, including MRIs prior to the procedure. And that's actually a critical step, because the MRI defines for us in many ways if patients are or are not candidates and eligible for the uterine fibroid embolization. Certainly, it turns out that a great majority of women are good candidates. We can then talk to their gynecologist and let the gynecologist know that from our perspective, this would be a good fit.
Would you agree that there's a fairly consistent ideal candidate that you deal with for IR, and what does she look like?
Certainly there are definitely consistent candidates. Those are ladies that are having bleeding associated with their fibroids. They're having pain and discomfort, pressure. They're having problems with urination.
When you talk about an ideal candidate, Dr. Ronbach, isn't it also a woman who does want some options when it comes to perhaps having children?
Well, that's an interesting question and not necessarily an easy question to answer. However, we have encountered over the years many women in whom they wanted to get pregnant, in whom hysterectomy was the only option that they had been given, the only choice that had been presented to them. And in those women, uterine fibroid embolization can be a really good alternative. And we've had many patients in my practice over the years in whom they were only offered hysterectomy, who have had UFE and had successful pregnancy afterwards. So it's an important option to consider, but not really the first line recommendation for women who want to get pregnant. It's only in those women who cannot have a myomectomy for one reason or another.
Best advice for a patient moving forward?
I think it's to be educated. Certainly you want to know the problem that you're having. Once that's been diagnosed, then we want to find out what your options are on treatment. And certainly you want to make sure that everything is shared with your gynecologist as far as what your long-term plans are. If you're married, then sit down with your husband, bring him in. Let's all talk about what the long-term plans are and how much this actually causes you downtime related to your job, your family, the way you feel. And certainly then we can sit down and say whether or not this procedure, interventional radiology with the UFE, would be the best place to go. But certainly it's a long-term plan. It's not something that's just done one time. You have to play a part in being involved in your own health care.
Would you agree? Empowerment, education, keywords?
Well, I think that in this regard, this is really quite simple. Women who know more are most likely to have the best outcomes and make the best decisions. And it's critical to evaluate all your options and know your alternatives to get the best result. There are complex decisions which need to be made when treating women with fibroids, but unless you know what the choices are, you can't resolve those decisions. And I think here the old adage really applies that knowledge is power.
Great advice from both of you. Thank you so much. We hope you found our program to be educational. Hysterectomy may not be the right option for all women. If you have fibroids, Don't just sit on the sidelines and ignore them. Talk with your medical team about the best treatment option for your lifestyle and health concerns.
My life is fantastic after UFE. I have more energy. People notice. They notice a difference at work. A week after the UFE procedure, I was training for the Against the Tides Challenge. I was at the YMCA working up to swimming a mile. It's important to ask the doctors questions because no one likes being sick. No one likes being laid up. I can't imagine anyone liking being laid up or being sick. And the difference between the past experiences and this experience is drastic.
If you have a choice, and I'm telling you, you do, don't just take what you're told. It's not the intent, maybe, of the physician to not give you all your options. It's not wrong to go back and ask questions. Ask because you never know what you'll find out. I asked, I fought, and I won. I'm another UFE success story.